Thank you, and thank you for this invitation. I first started 3D printing in 2001 at NIH and unknowingly was using Materialise software and a Stratasys printer, and here we are in 2017, 16 years later. What I'm going to talk about is about what we've done at Mayo Clinic over the past 8 years, and I've got 30 minutes to do so, so we're going to move rather quickly and see how much we get through. I do have some disclosures, like I was brought here to speak, and then my other life is I do tumor ablation, minimally invasive tumor ablation in the spine, sacrum, and head and neck because I'm a neuroradiologist. At some point, though, at Mayo Clinic, all of this 3D printing that we were doing had to move beyond just one-offs and interesting stories and things that were, cute stories that were happening and changing lives, but we had to develop a system that can incorporate all this different type of printing and healthcare under one roof in an enterprise that's fairly big. And to discuss that a little bit, I'll talk about why I got started, why Mayo does it. We'll talk a lot about case use examples, including education. We'll talk some about the challenges, quality, a little bit about our hospital administration, and we'll wrap things up, hopefully. Mayo Clinic, if you've never been there, has 3 main campuses. The first is in a small cornfield in the southeast corner of Minnesota, as the Mayo brothers founded it there, and the other 2 are in Scottsdale and Jacksonville that are slightly smaller institutions. But we have about 60,000 employees and about 1 million patients from 135 countries coming per year. And if you look at the number of surgeries we do per year, it's about 76,000. And you can see the scope. How could we incorporate 3D printing into such a vast, large organization without having a centralized approach in order to doing this? And really, the reason why it started and the reason it continues is because we had a clinical problem. We had a set of conjoined twins that came to Chris Moyer, one of the pediatric surgeons, and needed to be separated. And the anatomy, as you can imagine, is quite complex in that their livers were fused, they fused at the chest. And we have great medical illustration at Mayo Clinic, but the surgeons really came to us in radiology and said, can you make us a 3-dimensional model? And at first, people said, I don't know what you're talking about. And then someone said, like we always do in radiology, because we're service people, we say, yeah, sure, we could do that. And eventually someone found me and knew that I knew this, and Dr. Jane Matsumoto and I worked on this project. And there's all kinds of drawings that happen in the OR, but this is what we saw from the very first model we ever created. Surgeons of multiple disciplinaries stopped looking at the images, stopped looking at the whiteboard, and started talking in a way that they understand in real 3-dimensional space. And as they were separated and grew, and so our lab has grown, they're now even older than that. This is a slightly older picture, but more conjoined twins came, and they started asking. The surgeons are great because they ask for things they don't even know exist, and they don't have no technical limitations, so they just say things like, can you put the bile ducts in there and the arteries in there? Can you make us the chest cage? Can you fuse it? And again, what we found was this, that surgeons stopped looking at all of the data and started talking about what they know to do around the model. And hey, because they have to talk to a group of people, maybe there's going to be 60 people in a conjoined twin surgery that all have to understand the steps that are moving forward. And the model is used oftentimes to prep the OR, because eventually, if you're squeamish, you don't like operative photos, maybe you don't know that you don't like operative photos. There are multiple in this talk, and I suggest you look down. Usually the slideshow can show me the next picture, and I think I can see it. So this is, someone has to look down and decide, where am I going to cut this liver? Where is the bile duct? What is the vein? I cut one, there's blood everywhere. I cut the other, and we can move on. It's very difficult to understand, and the prints certainly help. They say, well, can't you just look at the images? Why does this help? That's kind of the standard radiology answer. And you can see it helps because of this. There's 4 teams of surgeons, all from different disciplines, that all speak a different language, that are centrally talking about the model. You say, why is the picture so blurry? Because I take pictures when I see them with my iPhone. We don't call medical photography all the time, because this is real life. This is what was happening that day. And I'd say that this happens after every model almost, because they're used to living in the real world, working on a 3-dimensional object. And I think this slide that talks about certainty has a lot to do with what we do, because 3D printing bridges this gap of taking the unknown and making it known. And you ask every surgeon, eventually they get to this point. Why does this help? They say, because there were things I could only know before when I was in the operating room. And this allows me to know things before I get there. Because if this child enters your office, you do not know what underlies there. You can get an x-ray, it provides information. You can get a CT scan, it provides more information. You get an MRI, you can make three-dimensional CT scans. You get an MRI, you get more information on the way, but until you print that object out and have it in your hands in life size, you're still in a state of relative uncertainty because it's difficult to understand all those images, and it's certainly difficult to know what size they are because they're as big as whatever screen I project them on. Now, this is that patient's model, and it looks monstrous on that screen, but I can tell you that this is helpful to the surgeon, and we partner with Materialise, who has been, I cannot say it enough, a great partner with us, because some of the things that we do would not be possible without the help of people like Todd Pieta and people in the US that collaborate with us, that have helped train us how to use their software in these events. Because our surgeons want things like, can you make the head come off? Can you make the spine split in half? Can you do this? I want to look at it this way. Can you put it on the operating table? You say, okay, you know, I'm going to call Todd. Take it easy. But here is the model. And if you walk into Tony Stan's office, which I did just to kind of give him the model, you can see not only is he holding the model in life size, he's already started to think about it before I even took this picture. He's moving it, saying, how am I going to put the patient on the table? I can't even get to this because the head's in the way. And if you look behind him, there's spines just strewn out all over. That's his clinic for the week in models. So we've fully incorporated into there. From twins, we clearly went to congenital scoliosis cases, not just the straightforward S-shaped curves, but the ones where all the surgical landmarks are going to be off. You know, things that get really complex. Scoliosis that where the patients are bent in half. How can you understand that as a surgeon, even if you had a CT scan? But when we print the models out, we use them to not only plan the surgery, but allow the surgeon to say, is this even possible? How much curve can we even correct without paralyzing the person? And then, like most things, the surgeon's walking around the ORs. We have ORs all strewn together on floors. The tumor surgeon says, what do you got there? You know, and the surgeon said, well, I got this model that Jay and Jane made me, and they come downstairs and say, I got this really large tumor in the cervical spine I have to remove. Can you help me with this? Sure. And once we went to tumors, there was no turning back. You can see the clavicle there has magnets in it, which the surgeons really like to be able to take the clavicle on and off. They say it's like the difference between Germany and France. It's the boundary that's really important for them. They're probably more meaningful over here. You say that in the US, you're like, oh, whatever, you know. But now that we're over here, it's probably very meaningful. And once we went to tumors, you can see there's no place within medicine that we do not touch in our lab with 3D printing, because once we got a lab in the hospital, centralized with space above the ORs, it just took off. Last year, we did about 600 surgical case models from our printers alone in the hospital. And this is an epidemic and also a social network connection. And our lab grew very similar to this, that we started here in the middle, and we had this central idea here, for example. And then the surgeon went to the OR. And when the surgeon went to the OR, another surgeon saw it, another surgeon saw it, another surgeon saw it. Then people in Jacksonville, in Florida saw it. And our lab grew very organically out of that way. For those of you who don't know, we usually use cross-sectional imaging for this, where we take CT or MRI data. We then have to segment out a portion of that data to get something like the vascular tree. Then we have to export that into some sort of CAD program. We use Materialise because we have to print these in different colors, but then we have to create connectors, magnets, split the things in different ways, which require us to use a CAD program that allows us to put those elements in. And then we choose what type of printer we want, and there's a lot of post-processing that happens after that. So you can see it's a really kind of elaborate scheme, and as the gentleman from Siemens had spoke, there are bottlenecks everywhere along this scheme that we need to solve. Sometimes we need to print in clear if we need connectors, like this child abuse case here, or in this mandible. Sometimes we need color, like in these oncologic cases, or they want the screws a different color than the tumor, or in patients who have large tumors of the face, they want the tumors in different colors. If we're creating simulation models, we might need flexible material. If we're going to land stents in them, we certainly need flexible material to be able to grab onto the stent. And these aortas were all designed with Materialise software in order for us, as I'll show you, to simulate complex care. We need to think about, are our materials sterilizable? Can I screw this 3D printed widget on there? Yeah, look away. There's people in the front row already looking away. It's before lunch, I mean. All right, this is the craniomaxillofacial section, so look down. Do not look at the screen, look away. Yeah, that's right. It will help your diet. You'll eat less and Materialise. Had ordered less lunch, they told me, because I was going first. Full disclosure. So here's a woman who just gave birth and has a lump on her hard palate. As she comes in with this lump, that's a bad tumor to have. That's an adenoid cystic carcinoma, high rate of recurrence, high rate of spread, and need radiation, chemotherapy, and surgery. She's obviously quite nervous. They asked for a model for several reasons. We have to make the skull, the mandible, we can put the tumor inside the skull in a place that you can't see it, and then we can print it, cutting it sideways. So black here is the tumor. It goes all the way up this nerve. And the surgeon, this is one element they can do. They just draw on it, say, I'm going to cut across tooth this and come across here. Now everyone in the room knows what this surgeon is going to do, where before only the surgeon had known. They show this to the patient. It provides a true informed consent to say what is going to happen to you. But as I can tell you, as someone who sees patients through doing tumor ablations, patients do not understand their imaging. It's very difficult for us to explain CT and MRI to the lay population, but this is very easy to understand. Here you can see we made some magnets so the mandible can be taken off. And this is one element. We produce a model that they use for preoperative planning. Now, things they do to them are things you can't expect. Like, you say, what did you do? You say, well, I cut the maxilla off ahead of time. I took their shoulder blade that you made me, and I made it fit exactly the way that I wanted it to do. So when I remove this part of the mandible and take this piece of the bone out, everything fits perfect. Now, they use these things in ways you don't understand. Sometimes people say, what's your plan for 5 years? And I say, well, I'll let you know in 5 years. I can tell you what's going to happen next year, but if you asked me 5 years ago where I'd be today, the answer would not be where I am today. Because things like they say, I love the model because I can bend the plate on the model. You know how hard it is to bend the plate on someone's face that we just resected a tumor from? It's difficult. This is simple, and everything fits perfect, so she ends up with a good cosmetic defect. Now you can take that the next step further and do virtual surgical planning where we do all the cuts on the computer ahead of time, and then our biomedical engineer makes these guides, and then we print the guides. Now that's not innovative in that people have done that in the past. I think what's innovative is we have everyone at Mayo Clinic under one roof. So when you come to Mayo Clinic, you see all your doctors, get all your tests, all within a week, because we live in a small town in USA, and people come from all over. They don't want to come back every 2 months. We get it all done at once. So we apply that to 3D printing. Here, the dentist and the prosthodontist come over with the surgeon, and we all make the plan together to give this person not only a correctly shaped fibula inside their jaw, but they're going to have teeth within the smallest amount of time frame that you can. Now, here's a patient. Look down if you don't want to see this. They have an abnormal mandible on the left-hand side. There has to be a cut there. That's a 3D printed, patient-specific cutting guide to remove this half of the mandible. And that also goes on the leg, and this is where the teeth implants are going to be, so the post can be put in at the time of surgery, and the prosthodontist has produced this implant so the patient wakes up with teeth. Because a patient with cancer, while they're concerned about the cancer, after the cancer's gone, they want to know, when can I go out in public? When will I look normal? When can I eat? When can I chew? Those are all things that are very important to the patient that oncologic surgeons don't always think about. Like this is a patient here with a large tumor in the maxilla. And what we did here is we made the cutting guides. The surgeon tells us where he wants to cut. We use Materialise software to help design these cuts, and then we use it to also make the cutting guides for this patient. We can mirror image the normal to the abnormal side, so we can make a normal face contour, because facial symmetry is very important. We had a fellow who was missing 3 fingers one year. Half the staff didn't even know. You have one lazy eye, everyone knows. Facial symmetry is dramatically important to these patients in a way that limbs and arms aren't. Then KLS Martin designed these plates just for this case, just for the way that we planned it. And then here's the printed object. So that's $9 of material, and it doesn't cost that in the market, but that's $9 of material for us because we're now in-house Class II medical device manufacturers. And that way was never possible in the past. You can look down if you don't want to see the next picture. Here are the models that we bring to the operating room, and then there is the guide that it's just for this patient, just for this tumor, just for this resection, and that all the plates fit together. So you say, how much does that save? That saved about an hour and a half in the operating room. Our operating rooms run at $80 to $150 a minute. So someone says, is that reimbursable? No, but we just saved tens of thousands of dollars of a case that's going to get one payment under a capitated system. Now, we do a lot of mirror imaging for patients who come with facial asymmetry and tumors. And you can see here we made the normal to the abnormal side so we can shave that down so it will be normal again when they wake up. We can design certain elements so patients like this who need their mandible resected can wake up like this. They still have facial symmetry. The results are beautiful because they're all planned ahead of time. All the cuts are made, and by the way, they wake up with teeth if it's benign disease. Every one of these people has had large portions of their mandible resected and taken out, and all of this is done at one time if you have benign disease, where you wake up with teeth. For malignant disease, we're down to 2 months, which used to be 6 to 8 months to get teeth. We do things like we design patient-specific implants, like this implant that was made with a MedPore for the skull. It fits perfectly, it's perfectly symmetry. We do work on craniosynostosis babies, where we don't do just the same surgery for every baby. These is work with medical modeling that we did where we create what should be the normal skull based on machine learning, based on normal skull values for a patient of that age, and then we design the skull that we want. We design a cutting guide that we want, and that cutting guide is then placed over the calvarium of the child in surgery. Sterile pencils are used to make all the cuts. This is all designed before you've even walked in the room, saving tremendous amounts of time in the operating room. And then all of these children, this will all form together as a solid bone in kids, and all of these children wake up morphologically normal. The results are spectacular because they're planned ahead of time, making the complications less, decreasing OR time, and having better outcomes. Now in thoracic surgery, this is Shonda Blackman and Steve Cassivi, two of our pioneering thoracic surgeons, and they wanted to do Pancoast tumors, which is a large tumor in the upper part of the arm with lots of blood vessels and nerves. The traditional is 1 week in the hospital, very large incisions, and it's very morbid to take these tumors out. They wanted to take them out through a keyhole. So they came to us and said, can you make models of the tumor? Here's Jane Matsumoto, my co-director, working with Shonda Blackman. She's telling us what's important to her and why they need this. And it happens during a work day. They come right up from the OR. The reason we're in the hospital is because it has to happen where the doctors are. They don't want to go downtown. They don't want to Skype for an hour. They don't want to meet an engineer. They want to come upstairs between cases within 10 minutes and tell us, I want this, 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 this. Thank you very much. Go back downstairs, and we do the rest. Now, this model was the first Pancoast tumor, and it included the trachea. It included the tumor. It included blood vessels, both arteries and veins. It included the brachial plexus, which has to come from an MRI. So we have to have ways of MRI and CT registering to each other. It included the bones. And you'd say, wow, that kind of doesn't look beautiful. You know, that Siemens wing blade looked much better than that chunk of plastic. But I can tell you that this was instrumental in them performing this surgery, and this patient left the hospital in 2 days with a very small incision. And this is one of our patients looking at his own tumor. There's no other way you can accomplish a patient looking at their own disease at life size, patient-specific ways other than 3D printing, and allows you to have a true informed consent about what's going to happen. Now this is that view through the keyhole, and they have to remove a tumor that's very large, and you can't see behind where you're going. And we do almost all the Pancoast tumors now this way. If you have to resect really large tumors behind the major blood vessel that pumps 5 liters per second out of your heart, it'd be good not to damage that. But this type of tumor has all these purple vessels associated with it, and if you cut 1 or 2 or 3, you're going to have about 2 liters of blood in your field and not be able to see anything right next to the heart. The surgeons take this, they study it, they stop talking to you, they start looking at the model and saying, how am I going to get to this vessel, this vessel, and take this out as one piece so that I don't leave any tumor behind. And the surgeon was so impressed in this case, this is Dr. Steve Cassivi, he said, I'm going to take a picture with it in front of the model to show how well it worked, and it saved time. Now, in renal urology, in renal sparing surgery, this is the chairman of urology who's probably taken out more partial nephrectomies than most people in the world. They are not people who jump on the bandwagon. Surgeons are not people that say, oh, you have a new technology? Let me jump in and try that new technology versus what I've been doing right for the last 10 years. They will only use things if it's helpful. So Brad came to us and said, I've got this patient that's got 1 kidney and a tumor. My chance of keeping him off dialysis is to only clamp the vessels that go to the tumor. Can you make me a model? And we said, of course, sure, we can make you a model. We have no barriers to anyone walking in our lab. If you're thinking of starting a lab, that would be my first suggestion. Do not put up barriers to people using this technology because they will use it in ways that you could never imagine. Here we had to design radiology protocols for 3D printing. It all starts with radiology, so we have to design protocols that are specifically planned for 3D printing. That's different than diagnostic work. And here was that first tumor, and he said, that looks nice, can you print me one with just the tumor and no kidney because I need to see inside where I'm going to be. I need to clamp just the vessels that are going to that kidney. Like this case, this is a horseshoe kidney. You can see it's shaped like a horseshoe. Sometimes kidneys don't split. Whoops. And in this case, we segmented the tumor, we segmented the kidney, the ureters, the arteries, the vessels. But when they're looking in there, this is what they see. This is the front. You can't see behind you. You can't see beside you. You have to loop out all the vessels you can see, but you can't see anything in the back. So they use the models in a way that they don't use the images. They hold it, they touch it, they think about it while they're using their hands, which is how surgeons think. And it was this little vessel in the back he was about to cut through, and he said, bring me the model. I only know this because he walked right up from the OR to our lab after this case and said, that model saved my bacon. I said, how? He said, well, there was this little vein in the back that I didn't appreciate on the imaging because the imaging is difficult to understand, and this is incredibly complex anatomy because it's abnormal. And he said, I almost cut that vein if it were not for the model, and then I would have had a bleeding vein behind where I can't see, and I don't know where it is. We'd have to pack it full. Would there be blood filling the field? And I said, well, that seemed like it really helped then. You got to be honest. Like, sometimes you're a little skeptical. We want to make more realistic models. This case happened last week. This is nice, orange kidney, green tumor, yellow where the urine is, red for vessels, but that's not what things look like. Our surgeons would like things to feel like they are, but I would also like them to look like they are. So we have this RTech handheld scanner we use for infant things, for creating custom devices. I said, let's take the scanner and go to the OR. So that's not the specimen. That's the scanned specimen after it was resected from the body, printed out. And this is that stellate scar that's so classic, that's so classic for this type of tumor, this stellate scar. The pathologists were blown away. We printed this out and brought it back to pathologists, to people who hadn't seen this case. This all happened last week. And stuff like this happens in the hospital on the fly. I had an idea. I said, I want to create more realistic things I said, just start calling surgeons, ask them what they're taking out. And sure enough, they said, I'm taking out a jaw, I'm taking out a spine, I'm taking out a pelvis, I'm taking out a kidney. Say, we're going to come up to the OR with our scanner and just start scanning, right? We have free access to all this stuff. And now we can put this back into our model, and we can print a model that looks real and teach people from it for the future. Oops, I'm going the wrong way, sorry. This is orthopedic oncology. This is Frank Sim. He's probably resected pelvises before CT scans were even invented. You say, Frank, why do you need this model? You're really good at this. He says, again, it lets me know things that I could have only known if once I got to the OR, and we've done about 20 of this. And once you start doing this, you don't go back. I asked them, say, let's do a randomized trial between model, no model, going into the OR. They said, no, thank you. They said, we'll take the model because it's helping us improve patient care and reduce complications. Nobody wants to have complications, particularly in these large surgeries, which can take 12 to 15 to 18 hours. So here's a 38-year-old woman with a really large tumor in her pelvis. It's blue here. This is her bladder. These are vessels. You can imagine someone saying, we're going to have to take the whole pelvis out, the uterus, everything, if you want to survive. Uterus, bladder, it's all going to come out, and this is going into the hip. We're probably going to have to take the whole right leg. We printed this out, and the surgeons looked at it forever, and he said, I think I can save this hip. And again, it's not color-coded in here. They have certain routes they can take, certain saws they can use, certain angles they can get at these tumors. And the models changed things for them because in this case, they said, we can save that hip. And when this tumor came out, it came out in one big piece. You can't leave any behind, or it'll have a recurrence or a metastasis. And they put this leg up here and made a neo-hip out of it. To have your leg when you wake up, it was because of that model. There's no question. The surgeon said, I was going to take that hip. That's what I do for these tumors. And that woman woke up with a leg because of the model and because of a talented surgeon. The model is a tool. It's only a tool to help very talented surgeons. And I love this quote because if it says, if you do them the same, you'll get the same outcomes. In order to change the outcomes, we have to do something differently. And at Mayo, we're not waiting for someone to pay for it. We're not waiting for someone to come up with all the regulation and uses. We're doing that prospectively. These tumors, like the blue, you can't see this from the outside. In the past, the surgeon wants to get a negative margin, they'll cut way out here, which takes more of the pelvis, more of the sacrum. Now they can see and bring the models in there and see exactly where they need to cut. Where are all the crucial vessels? Where are all the crucial nerves? These are complex anatomic relationships. You cannot appreciate at surgery because you're looking through a small hole. And one of the things this does is help you see the forest through the trees. And these aren't just models, these are people. This is a 30-year-old woman, a 51-year-old with a refractory tumor, a 51-year-old chondrosarcoma. The list goes on and on and on. Because in patients like this, where you've already taken half of the pelvis off and there's a recurrence, they want to know exactly where the screw is, exactly where the recurrence is. Because how much more of her are you going to take? Are you going to take the other leg, the rest of the pelvis? If it's up to her, obviously not, because she's very active despite having a hemipelvectomy. Now, I talked about this, seeing the forest through the trees. Now, this tumor involves multiple blood vessels and nerves that you don't want to get into, but here's the surgeon's view. This is the beating heart, and this is their view. They would like to be able to see everything around it, but that's not a reality because they need to resect this. And in this case, I walked up to the OR to see what was happening because I knew this case was going on. And they said, you see this little bump right here? And they said, we thought that was the rib after we took the tumor out. We brought the model over, and there's no question that's tumor. So they write in the case, they use the model to determine anatomic relationships and what tumor was and what tumor wasn't. These are life-size. Our surgeons want life-size things. If it's a 1-year-old, like this child abuse case, they want it printed in life-size. This is Joe Duraney, who works on hearts and blood vessels this size. And they use it to teach in the operating room. These are just pictures I took while I was delivering models and going up to the OR. They're using it to show their residents and fellows what's happening in a way that you couldn't without the 3D printed models. Now, in orthopedic surgery, it's almost a no-brainer to use 3D printing. That's Andy Sems, and I'll illustrate this through this one case of severe bow ligaments because they have Blount's disease where the growth plates are fused. They asked us for a model. I said, what are you going to do with the model? They said, I'm going to plan this type of surgery. You say, oh, it looks like they just took a wedge out. That wedge is extremely important, both rotationally and the size of it, what you make at every angle of that cut. So we used this model to go to his garage, that's where we went, and made a lot of cuts to determine this is a computerized plan that says we're going to put all these pins in these different places, and it's a distraction. So you break the leg, you separate the bone by millimeter, and it takes that bone and it'll make it normal. So if you look at how she walked before, let's see, almost? No? We'll see if it plays. It was playing earlier.
She gained 9 and
you can see that she came in like that at the top, and at the
happy
bottom
with
is how she
Mayo.
left. Now, 3D printing played one role in that. It was a tool to take Amarachi from something like that to something like that to a fully functioning, normal-looking girl, which is really important in her country. And that's the wedge. For cardiology, this is the size you're operating on. I keep pressing the wrong button. Sorry, Freed. This is the size you're operating on. You know, this is an infant's heart. They have to operate in blood vessels inside of here, and these two talented surgeons, they don't use it for every case. They use it for complicated cases they don't understand. They use it for planning. Will this device fit in this area? Can I educate the patient with this device or the parents of the patient? Can I teach my students what a rare anomaly looks like? Because they have this subset of knowledge, and through the years they've connected all the dots with this experience, and they really want to be able to shorten the gap of their trainees to get from knowledge to experience. And 3D printing does that because it allows you to decrease your complication rate. If you want a good surgeon, you get the one that's already got the complications out of the way, right? Like 10, 12 years in, you don't want the really old guy with shaky hands, but you don't want the young guy who just finished, you know. We're trying to make that slot happen faster. We do things like deploy valves. These are really expensive valves. You put in one that's the wrong size, a millimeter or two, you just wasted a lot of money, and you're not going to get paid more because you used a second valve. We educate people on rare conditions such as Ebstein's anomaly in the heart, and we can print things that come apart. We use magnets, but that's just one more instance where you need a CAD program in order to do this. This is a case with a large tumor on the heart, and they were going to resect this tumor, and they said, okay, we'll make a model. I said, how did you use it? They said, well, we used it to plan the resection, plan the graft, but then we used it like this. We mapped out where the borders of the tumor are, and we brought this to pathology. Why? Because pathology is going to look at every margin and see, do you have negative margins for tumor resection? And they usually say, okay, tell me which margin was positive. The pathologist says, I don't know. One of the margins is positive. You know, you need to go back in there. Now they could say, in this superior quadrant, with this tumor model and this specimen, the positive margin is right on the corner. You need to go back and enlarge that resection. And the pathologist it's just another use we didn't expect. The pathologist here got models, and they started teaching their residents and fellows because they don't get gross pathologic specimens anymore. In the neurosciences, we do a lot of skull-based tumor resections. This is Mike Linker, one of our two skull-based surgeons at Mayo, and they order models for complex cases like this, where the patient's already had surgery somewhere else. Someone's got what we call a wallet biopsy. That means they took a little tumor out and put a lot of metal in and charged you a lot of money, but they didn't do anything. We call that a wallet biopsy. Maybe you've had one. You know, but they have to plan, how am I going to get this out? And how am I going to tell the patient about what I'm going to do? So it asks us to cut it. I want to look at it. Where is this blood vessel? Because that feeds the brain. I don't want to damage that. And what is the size of the hole that I have to fill in order to make this person's head not fall off their neck? And they usually show them the whole one after they've had their surgery, and they say, look, the tumor is gone on the model just as it is in you. Again, I wouldn't have thought to use that. We have to teach people. We have over 1,000 people we have to teach for medical education. It's the largest graduate medical education, and we have people like myself who have to take a certain body of knowledge that I have and give it to 13 residents a year, a PA, a medical student, visitors, all kinds of people that come. I have to tell them what I know, and it's difficult without using these three-dimensional models. For simulation, what if you want 28 elbows that all have the same deformity? You can't order a cadaver that's got a certain deformity. What if you want intracranial vessels that all have the same abnormality? What if you want to teach people how to take a pectus model like this and then expand? You have to put a bar across the chest and flip it upside down and pop the chest open. Good if you know how to do that, probably not good if you've never done it before. And we create models out of patient scans in order for the fellows to practice before they even walk in the room. We create VATS models that they bring to international meetings and tie organs in and teach people how to do certain procedures. This upper right case is really interesting because they wanted a medical illustration of this, and the medical illustrator who's been doing this for 25 years at Mayo came upstairs and says, I cannot believe how good this is, how I can see this, how I usually have to make this stuff up in my mind. Now I can just take a picture of this, go back to my office and draw it. Will be done in a day versus a few weeks of me figuring out all the anatomy. You know, so that's a way that we never would have thought of that. These are 3D printed cadaveric tissues. So in some countries, you can't use cadaveric materia. When the Ebola crisis broke out, all of a sudden there's no cadavers in that part of the world. People still need to learn. This is some of the work at Monash University that we partner with on the left, and some of the work that we do on the right. And there's students working on cadaveric parts. Now, I think this project is one of the more fruitful ones that we did in Mayo, and it shows the benefit of in-house printing. Here's a patient who came with an aortic aneurysm. He wasn't a surgical candidate. It had something called potential rupture, means it's going to burst. They do not have a stent that could cover the carotid artery. So our vascular surgeon came to us like, can you make a model? I'm going to have Gore make me a stent for this patient. It's going to happen within 3 days. And we said, okay, we'll try and figure this out. We made this first prototype in 3 days and had a working model with flexible internal material and hooked it up to a pump system, and this is that patient's graft. This happened in 4 days. While that patient was going to sleep, the surgeon was putting a patient-specific graft in a model in the next room so he would practice once before, something he had never done before because it had never been done. Now, that's Gustavo Oderich there that does these cases. We now have done about 15 to 20 patient-specific custom branch stent grafts that are only made for that patient's anatomy, and we hook these up. He's also run courses. People come from around the world to learn how to do this. So between him, us, and Gore, we run courses at Mayo Clinic where they'll watch a case be done and then go do it on the model of the anatomy they just saw. And here's that patient. You can see multiple steps, but this happened literally in 3 days because we were in-house. We do simulation of rare events, like this is Dan Price, one of our ENT surgeons. That's how they look when they get the model, by the way. They're always happy. He wanted to teach his fellows, what happens if you're down the nose and you break into the carotid artery? It's a rare complication, it happens. Your blood fills your entire field, you can't see anything. Well, it's better to teach someone that in a controlled environment. We teach people how to put in interventional pulmonary stents. Some of the future, we do work on bioprinting and bioscaffolds. We're in large animal models for bone. We just finished goat trials, dog femurs. That's going to be probably one of the first things about bioprinting that comes into reality. It's not going to be a kidney or a liver or a heart or any of this other stuff that I think is way blown out of proportion. But bone, trachea they're already doing, cartilage are already doing, but bone, we have bone that we can grow in patients to keep metal out of them will be really important. There's certainly companies that are doing tissue engineering. There's people that are creating tissue to test drugs on. There's the partnership between Materialise and University of Michigan about the tracheobronchial Malaysia stents, which is a great story if you have time to look into it. And there is a first trial of skin printing opening up last month. Now, challenges, the payment structure is a big one, right? Time to model is another one. We have segmentation software that's phenomenal, but it is still the bane of our existence, taking patients' images and getting them to a point where we can print. It is one of the bottlenecks we have to solve, and Materialise has been a great partner in helping us solve those problems. So there's print time. I can't control how long the printer takes, and it does take quite a long time. Some of the full pelvises I showed you took more than 70 hours. We had a 101-hour full adult thorax massive tumor case that just finished on the printer this morning. There are other things we had to think of right off the bat. We were going to do this in-house, and while the stories of 3D printing are interesting in the media, it's more difficult if you're going to incorporate this into a hospital system. We have to say, does our printer work the way we say it works? We had to create phantoms, bar phantoms that we use in radiology for 3D printing to prove that our printers work the way we said they did. We created more robust phantoms to say, like, if we're printing blood vessels, that this is accurate, because one right-left mistake, one mistake in size, one mistake in sizing a pediatric instrument, and you've just wasted a ton of money, not to mention it could be litigious. The printers, they have to get faster, they are. They have to get more reliable, they are. And the materials are getting better. Now, we had to create ordering and deliverable systems, sterilizable processes in-house. And we had to create a manufacturing infrastructure that never existed inside the hospital before. Right now, we're building a GMP, and 3D printing of things is going to be into it. We focus as radiologists on the imaging, and I think it's very important because that's a huge bottleneck, because about 25% of people have a lot of metal in their body, and you cannot segment that to print. We have to use techniques that we've developed for other reasons, like dual energy scanning, like multi-energy scanning, like iterative metal artifact reduction that can take parts of the body and separate different densities of the body just based on the energy we put in on a CT scan, like this heart right here. We use things like iterative metal artifact reduction to get rid of this artifact, to make 3D printing faster. We had an ordering system which requires a consultation with a physician. We had to integrate it into our radiology information management system so it would trigger the right order. There's all sorts of post-processing. There's vents we had to create in the ceiling of the hospital because these things have toxic fumes, some of them. And this is Dr. Matsumoto and Amy painting. They like to paint some of them. It's cheaper to print in white. It's just the way it goes. And then there's some magnets because our surgeons like to take them apart, like I showed you here. This is our patient image viewer. The patients can see this. The doctors see this. It's fully incorporated into the system. Now, we were just talking about our 2020 plan for Mayo Clinic recently, and I was asked to present, and they said, well, how does this fit into our plan? And I said, how does it not fit into our plan? At the very basis, we're investing in talent and technology. This is a technology that's revolutionized the way that we practice medicine and surgical operations at Mayo Clinic, which transforms the practice, achieves operational excellence, generates ongoing demand. These people put these on Twitter, they Facebook them. It's the best word-of-mouth advertising you can get, and we deliver the highest value care from the most trusted institution at an affordable rate, which is our goal. So I think 3D printing has a wide role in the medical field. It helps in multiple things we've talked about. Their advantages are numerous, which I hope I shared with you. There are a lot of challenges to overcome. It is not simple. The technology is advancing at a rapid pace, but you have to remember at Mayo Clinic, it is 100% about the patient. 3D printing is a tool. So when you look at this baby here who's born with this is an in utero ultrasound. Do you have a mic? Yeah, I'm loud. I'll point because the pointer's not working. That's his heart outside. Sorry, I know I'm going over, so I might as well walk around. This is the heart outside the body. This patient had something called Pentalogy control. There's a 97% chance that child will die as soon as it hits the air. And I can tell you that we made some three-dimensional views of it. There's the baby, and the parents, they're counseled, right? You should terminate the pregnancy. You should I don't want to, this is our baby. I do not want to terminate the pregnancy. I want to give my baby every fighting chance it has at having a life. So I sat in a room with 21 people after we made this very crude model from an intrauterine MRI, which I thought wasn't very fancy or phenomenal, but sometimes they don't have to be. The bottom part that's sticking out in the abdomen, the green, that's his liver. The yellow is the heart. And they wanted to know the size of the defect. And 21 surgeons and physicians sat around with this model saying, what if you do this? How about I take the liver out more? That won't be a problem. We'll make an incision, take more liver out. We need to get the heart back inside the body. And what is the physiology of the heart? They all sat around talking to the model, essentially. And they all had a sense of understanding by touching something in a way you cannot get from the pictures. And this baby was delivered by what's called an exit procedure. That's the baby coming out. And someone's sole job was to hold the heart so it didn't twist. There were about 21 people in this operating room trying to get this baby out and keep that heart beating, not go into a fatal arrhythmia, not twist, not kink. This is Carl Rose here, who it looks like he's praying, which is really nice because maybe he is. But that's how you stand in the OR to keep your hands sterile. And this is Joe Duraney with the baby delivered. Now, that baby stayed in the hospital for a couple months, but these parents left with a baby that was live, that was healthy, that everything Mayo Clinic had to bring to bear was brought to bear, including 3D printing that helped save this child's life. So we are great collaborative partners. We are very appreciative of Materialise and our relationship with them because you cannot imagine the things that you can do when you collaborate with other people, because 1 and 1, it definitely makes 3 in our book, and imagine what we could all do together. This is a number of people who work with us in our lab. I wish our lab was even bigger because we could do more, but thank you very much. Sorry for being so long.